Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. This is a continuation of the series of lectures regarding the diseases of nasal septum. And today we will talk about a very important topic as far as uh, exams are concerned, or clinically as well, because this is a very common ailment. So let's start today's discussion. This is what we call as deviated nasal septum or deflected nasal septum. This deflected nasal septum, it is labeled as when it is causing symptoms. Now, this is very important in the definition that a septum will be labeled as deviated nasal septum or deflected nasal septum when it is causing symptoms, because as we will see in the etiology, the trauma is the main etiological factor. In majority of the population, the septum is either deviated towards one side or the other side. It is not exactly geometrically in the midline. So it doesn't mean that every one of those should be labeled as a case of DNS. DNS is abbreviation for deviated or deflected nasal septum, or they should be subjected for surgical correction of the nasal septum. Only we will label it as when it is causing symptoms, because it can be an incidental finding, and patient would have come to you with some other complaints, and you just examine the nose and septum may be acutely deflected, even touching the midline, and when you ask the patient any nasal symptoms and patient denies that, then it is okay. So deviated nasal septum is when it is causing the symptoms. Now in etiological factor, trauma is the main etiological factor. This is an MCQ as well. They can ask you. All these can be etiological factors like developmental errors, racial factors, or hereditary factors. But if you have to choose a single one, then this is the trauma. Now, what kind of trauma it can be? It can be different types of trauma. That is, lateral blow on the nose may cause displacement of the septal cartilage from the vomerine groove and maxillary crest, and this lateral blow may be during assault, during traffic accidents, it may be during sports injuries. Same is a crushing blow from the front may cause buckling, twisting, fractures and crushing of the nasal septum. Then trauma can occur during delivery, that when during normal delivery the nose may be hit against the pelvic bones, and even during intrauterine life when the fetus is moving in the uterus, so it may be hitting against the walls of the uterus. Then as a toddler we know that the baby is hitting against the floor, against the tables, against the chairs. So briefly, the history of clear cut sports injuries or road traffic accidents may be available or not, like this trivial trauma during childhood, during delivery, during intrauterine life. But still, the main causative or main etiological factor of deflected nasal septum is trauma. Developmental errors can occur like nasal septum. It is formed by the tactoseptal process, which descends to meet the two halves of developing palate in the midline. So during primary and secondary dentition, further development takes place in the palate, and unequal growth between the palate and skull base, it may cause buckling of the nasal septum. Or in mouth breathers, especially in those patients who are having adenoid hypertrophy and they are having a problem with nasal breathing, so they become habitual mouth breathers, so there will be high arched palate, and this high arched palate it can cause the twisting of the septum, and then there can be a deviated nasal septum in high arched palate patients. Same is the case with patients having cleft palate, cleft lip, or dental abnormalities. Then Caucasians, they are affected more than Negroes, it has been observed, and some members of the same family may have deviated septum. So some people have proposed hereditary factors involved in the etiology. But again, I am reiterating, out of all these etiological factors, trauma is the single most common cause of DNS. It can be cartilaginous deflection, or it can be bony deflection. Bony spur may be there, or both may be deflected. Then deflection can be interior, or it can be posterior. That is what we divide with the Cottle's line. I come to that in a while. It can be a high deflection, or it can be a low deflection. This Cottle's line, it is basically a vertical line between the nasal process of the frontal bone, this nasal process of the frontal bone, and this and nasal spine at the maxillary crest. So this is a vertical and imaginary vertical line, which is called as Cottle's line, and it divides the nasal septum into anterior part. So this is the anterior part, and this is the posterior part. So if deflection is here, somewhere here, it will be mainly cartilaginous, and in the anterior part, posteriorly, it can be cartilaginous or it can be bony as well. There can be anterior dislocation, there can be C-shaped deformity of the nasal septum, or S-shaped deformity, or there can be only bony spur at the osteocartilaginous junction, or because this is due to trauma, there may be septal hematoma which was neglected, so it became organized. Instead of being infected and leading on to septal abscess, it became organized, and that led to what we call as thickening of the nasal septum. So this is the diagrammatic presentation of this. This is the this maxillary crest, and this lower part of the nasal septum is supposed to be placed here, but it becomes dislocated from here. So this is what we call as anterior dislocation. This is also called as caudal dislocation. So caudal dislocation of nasal septum or anterior dislocation of the nasal septum is one and the same thing. Then if this septum is deflected towards one side of the midline, then we call it as a C-shaped deflection. This is the midline. If septum is deflected towards one side, then it crosses the midline and this deflection goes towards the other side, then we call it as S-shaped deflection. And this is a bony spur along the osteocartilaginous junction, and this is the thickening of the nasal septum secondary to trauma, and septal hematoma has become organized. So these are different types of deflected nasal septum. Now in this patient, if you closely observe, here you can see that this one is the caudal border of the nasal septum, which is supposed to be here in the columella. So it is being displaced or dislocated from the columella and inferiorly from the spine of maxillary crest. So this is what we call as anterior dislocation. This is also called as caudal dislocation. I told you this is one and the same thing, because when we describe it an anatomical position, patient is standing like that. So this is the caudal part and this is the caudal border of nasal septum. But just like in the picture or on the operation table, patient is lying and we are looking at from the anterior, then we say this is the anterior dislocation of the nasal septum. So anterior dislocation or caudal dislocation of the nasal septum is one and the same thing. Only difference is that caudal, when we describe it in anatomical position, and anterior dislocation when we describe it on the operation table. This is endoscopically This is the nasal septum here on this side. Sorry, this is the lateral nasal wall, and this is the nasal septum here in the midline, and here you can see this is the spur. Otherwise, rest of the nasal septum is in the midline. So this is bony spur which is impinging on the lateral nasal wall. So in case of C-shaped deformity, there will be nasal obstruction on the convex side. On the concave side, there can be obstruction because of the hypertrophied inferior turbinate, and this is called as compensatory hypertrophy of the inferior turbinates, especially because when the septum is deflected towards one side, on the concave side there is more space, there is more vacuum, and this space is being occupied by the uh, engorgement of the blood vessels over the surface of the turbinate, and so that the turbinates try to occupy that space to avoid excessive crusting and dryness of the nasal cavity on that side as a protective function. But in the result, there is hypertrophy of the turbinate, and this hypertrophy of the turbinate will lead on to nasal obstruction on the concave side as well. So this is what we call as compensatory hypertrophy of the turbinates, and this deflection of the nasal septum not only in the nasal cavity, but it can lead to external deformity of the nasal bridge as well. There can be impairment of the drainage to the sinus because of inequality in the lumen of the nasal cavity, and we know that the paranasal sinuses, they open in the metastasis, and then there can be secondary atrophic rhinitis due to excessive crusting and dryness. So nasal obstruction is the main symptom of deflected nasal septum. In S-shaped deformity, we can expect the bilateral nasal obstruction. In C-shaped deformity, there can be unilateral nasal obstruction, which is quite expected, but there can be bilateral nasal obstruction in a C-shaped deflected nasal septum due to the compensatory hypertrophy of the turbinate on the concave side. So, if we have to single out nasal symptoms of deflected nasal septum, then it will be nasal obstruction. Then of course there can be headache, and there can be problem with the drainage of the sinuses leading on to the infection of the sinuses, which will cause sinusitis and its signs and symptoms. Then there can be nasal bleeding. It can be due to the excessive dryness and crusting, because if septum is deflected, for example, on one side, more air will be going on over the little's area, there will be dryness, there will be crusting, and when these crusts are removed, there can be bleeding. And if there is a bony spur, so sharp bony spur is there, and mucopericordial lining is stretched over that, and due to that sharp impact of that bony spur, the mucosal tear becomes easy, and again there can be bleeding. And as I told you, not only inside, but there can be external deformity as well, and due to the postnasal drip, there can be soiling of the eustachial tube orifice leading to the middle ear infections. So nasal obstruction, that is the main hallmark of deflected nasal septum. This nasal obstruction can be there at the nasal valve or vestibular area, it can be in the attic region, or it can be posteriorly in the turbinal area or in the choana. And obstruction, it can be bilateral, it can be unilateral. There is a simple test which we call as Cottle's test, and this is that patient is asked to retract the cheek with the 2 or 3 fingers, as you can see in this picture. And if the patient feels there is improvement in nasal obstruction on that side where this cheek is being retracted, that means that the abnormality is in the vestibular component of the nasal valve. So this is a very simple clinical test which can be done in the clinic, simply ask the patient to retract the cheek on the side of where there is a complaint of nasal obstruction, and if it improves immediately, it means the obstruction is at the nasal valve level. And by the way, Lyman nasi or nasal valve is the narrowest area of the upper respiratory tract. Now there is the Cottle's line, Cottle's test, and Cottle's areas. So these are three different entities, so don't confuse them. So in addition to nasal obstruction, which can be unilateral or bilateral sites, there can be headache, sinusitis we just talked about, then nasal bleeding. Due to nasal obstruction, if there is acute deflection of the nasal septum, the air could not be conveyed to the olfactory area, so that there can be problem with the smell, olfaction. There can be anosmia or hyposmia. External deformity or middle ear problems can also be there. In the differential diagnosis, we have to think about the polyps, septal hematoma, and hypertrophic turbinates. Exams are always tough. So, minor deviation with no symptoms, they require no treatment. No treatment required when there is no symptoms. Because by definition, we have agreed that a deflected nasal septum is labeled as a deflected nasal septum only when it is causing symptoms. And if we have to single out the symptoms, then it will be nasal obstruction. So when deviated nasal septum, it is producing the nasal obstruction or other symptoms, then surgically we have to correct. And there are two operations which we can do. One is, most commonly it used to be done before, it was a radical surgical procedure which is called as SMR. This SMR is basically abbreviated for submucoperitoneal submucoperiosteal resection of the nasal septum. So as the name indicates, that we have to raise the flaps and we have to remove the nasal septal framework. But usually it is called as submucous resection. Technically, uh, there cannot be any plane under the mucus, because mucus immediately you can suck it out with the suction machine. There will be no mucus, so how you can go in a submucous plane? So technically it is submucoperitoneal submucoperiosteal resection, but now it has been replaced by what we call as septoplasty, and this is a conservative surgical procedure. So nowadays we prefer septoplasty, in which only the deflected part of the nasal septum is either realigned or it is being removed, and rest of the septal framework is retained. In some other videos, we will discuss in detail the indications, contraindications, and procedure of these surgical procedures for nasal septum. So with that, we come to the end of today's discussion. Thanks for watching, and don't forget to subscribe the channel.